This is a patient referred with a fixed dilated atonic pupil after retina detachment repair. The iris is adherent to the cornea for about 4 clock hours, causing glaucoma. Here we're going to dissect the iris away from the cornea using viscoelastic. And you can see I'm working around from two different paracenteses and creating a separation here so that the iris is now away from the cornea. And now we're going to go ahead and do an iris cerclage, and I'm using a pupil sphincter sparing technique here. This is a CTC6 needle that's being placed through a paracentesis, and I'm going to use the Sinskey hook here to push the iris back further onto the needle and sort of give me a second hand assist here, some counter traction. I've done 3 or 4 bites here, and now I'm going to uh, grab the tip of the suture with a 27 gauge cannula and pull it out through the second paracentesis, which is 90 degrees away. I'll inject a little viscoelastic. And now, as I push the needle through the paracentesis, I want to make sure there are no stromal fibers. Again, doing 3 or 4 bites per quadrant. I'm going to use a micrograsper here to assist me a little bit and hold the iris, kind of pinch it, and now pull this out through my paracentesis. Uh, you can see that I am not wrapping the suture around the iris sphincter. I'm doing a cerclage inside, about 1 millimeter inside the pupil border. I've now switched and I'm going to use my left hand to drive the needle, and the right hand is going to assist with the micrograsper and do a little bit more of the work for me to kind of push the iris onto the tip of the needle and create like a iris shish kebab here on the needle, 3 or 4 bites per quadrant. When I do a pupil sparing cerclage, I need less bites per quadrant because it's going to be a smoother edge to the pupil because the suture is 1 millimeter back from the iris border, so you're less likely to get that zigzag, jagged star shape of the pupil. You also put a little more tension on the peripheral iris as you bring the pupil down, which is what I wanted to do here. I wanted to prevent iris creep into the angle. So here I'm going to brush the iris back onto the noodle a bit using a Sinskey hook and make one more pass. I think this is my 4th pass in this quadrant, and pull the tip of the suture out through the paracentesis. Now I've gone 360 degrees around. I'm going to go ahead and do a 3-1-1 tie, and I've got to be careful not to make this too tight. I don't want to make the pupil too small, so I'm going to go ahead and bring the knot into the eye and then gently tighten this. And you can see here I am bringing it down about to where I think I want it to be to match the other eye. I'm now going to loop this out and I'm going to lock it with one reverse throw. Pull this into the eye and lock the suture. And then I'll go ahead and do one more. So this is a 3-1-1. This is my last throw here. And so now this is locked in place, and I cut this with a micro scissor. And then you can see the pupil looks really nice and round and physiologic. I'm going to go ahead and do a goniotomy here with a KDB blade, as this patient did have secondary glaucoma. I'm going to go about 3 or 4 clock hours in each direction and remove the inner wall of Schlemm's canal. We'll now remove the viscoelastic with separate irrigation aspiration hand pieces, and I can actually pull on the iris board a little bit to round this out a little bit more, and this looks really nice now. And in this case, I chose to put an air bubble in to prevent bleeding from the goniotomy. Thank you for your attention to this case.